Today we will discuss about an important concept of endocrinology and general practice, hypothyroidism. So we will discuss in detail about hypothyroidism. First few segments will be very basics, mainly for undergraduate students. Then we will discuss frequently asked questions or frequently faced problems in clinical practice, which will be very helpful for postgraduates as well as practitioners. So we'll start now. So mainly hypothyroidism, we will discuss it based on evidences, mainly to help in diagnosis, treatment and long-term care. This is our motto today. First of all, hypothyroidism is defined as a clinical syndrome resulting from a deficiency of thyroid hormones. This we all know, leading to generalized slowing of the metabolic process. So we know that thyroid hormone is very much essential for maintaining basal metabolic functions. When the hormones are in lesser quantity in our body, it will lead to slowing of metabolic processes. And this syndrome is characterized by some typical biochemical features. For example, there will be low levels of circulating free T4 and often we see associated elevation of TSH. So this will be the common picture, right? So if we focus on the image besides, thyroid gland is not functioning up to the mark, especially in case of primary hypothyroidism. That will lead to slowing of the metabolism and it will lead to some effects in the cardia as well as brain. Overall, it will affect all possible systems of our body. So the presentation of hypothyroidism, commonly what we see, is very discrete, we can say. Individuals can present with any of the system involvement. So we can tell that symptoms are often subtle, non-specific, and they will develop gradually, making clinical suspicion the crucial first step. That's why if we know the symptoms of hypothyroidism, we will be able to suspect the case very early in the disease process. So common symptoms with which many individuals will present are fatigue and lethargy. So this will be the very commonest presentation. There might be cold intolerance, skin might be dry, and there will be history of hair loss, history of constipation and cognitive slowing, difficulty in concentrating. Then there might be evidence of bradycardia and they will be gaining weight in spite of poor appetite. These are all few presentations of hypothyroidism, and in females they might present with menorrhagia as well. Menorrhagia. So these are some presentations. Now we have to know who is at risk of developing hypothyroidism. So there are some factors which can tell that this individual might be at risk of developing hypothyroidism. For example, when it comes to gender, females are 5 to 8 times more likely to be affected than males. Then when it comes to age factor, as the age increases, for example, if it is more than 60 years, there might be chances of hypothyroidism, because we know that as age advances, there will be slowing or decrease in the production of multiple essential hormones and enzymatic processes. One among them will be thyroid hormone, leading to hypothyroidism. Then family history is also a deciding factor. Suppose there is some autoimmune disorders in the family. In particular, if they have autoimmune thyroid disorder diagnosed already in other family members, the risk of developing thyroid disorder, especially hypothyroidism, will be higher. Similarly, type 1 diabetes, autoimmune disorders in the family. Then any prior history of thyroid injury, for example, radiation to the neck or previous thyroid surgeries, if they undergo, obviously there will be chances of thyroid gland disappearance leading to hypothyroidism. Then one more situation is postpartum. So the risk of hypothyroidism will be more in first 6 months after delivery. This is called as postpartum thyroiditis. So these are some risk factors, and if we observe here, majority are related to females, right? So we commonly see female hypothyroid patients more often than male. Coming to the classification of hypothyroidism, mainly we will divide it into two things. One is primary hypothyroidism, secondary hypothyroidism. So hypothyroidism is classified based on anatomical site of dysfunction. So primary in the sense the problem will be in the gland itself, thyroid gland itself. So it will not be able to produce enough thyroid hormones in spite of adequate stimulus from pituitary gland. So this is primary hypothyroidism. Whenever there is decreased thyroid hormones, it will stimulate the pituitary gland. There will be negative feedback mechanism, right? Which often leads to increase in TSH production. Again, it will try to come and stimulate the gland to produce as much as possible. This will be the common picture. So the gland will try to produce thyroid hormones again. So commonly we see there will be either decreased T3, T4 levels, or if the TSH is trying hard, we can see in the initial stages T3, T4 might be still normal. But as the disease progresses, this TSH will not be doing its action even when its levels are very high, because the thyroid gland disease is progressing a lot. In such situations, we see very high levels of TSH with low levels of thyroid hormones. This is all related to primary hypothyroidism, and commonly more than 95% of hypothyroid patients are related to thyroid gland per se. So primary is very common. When it comes to secondary hypothyroidism, it might be either problem of pituitary gland or the headmaster, that is hypothalamus itself. So if it is pituitary related, there will be decreased TSH production. So when the stimulus itself is low, obviously T3, T4 will be low. So this picture we will see in secondary hypothyroidism. Similarly, if the problem is in hypothalamus, there will be decreased production of thyrotropin releasing hormone, which in turn again leads to decreased TSH, again leading to decreased T3, T4. Here, when negative feedback mechanism gets activated, it will try to stimulate, but the problem is in higher centers, so they will not compensate by producing TSH. That's why the levels will remain low only. This is central or secondary hypothyroidism, but the incidence is very less. We can say less than 5%. This is the classification of hypothyroidism. Now we got to know who is at risk and what glands problem might lead to decreased production of thyroid hormones and how they might present with. So once they present with all these things, and if they are at risk factors, how we have to work up. Initially we told that some signature biochemical markers are there, and we have discussed it already. Just we will summarize it. First and foremost thing is serum TSH. This is single most sensitive screening test for hypothyroidism we can consider. So suppose there is primary hypothyroidism, there will be elevated, compensatory elevated TSH. In secondary, it will be decreased. Next test, which is very important for us, is free T4 levels. So it will directly measures the active hormone, and we know that when the disease progresses, thyroid gland will not be able to produce any T4 or T3. So in such progressed diseases, we will see low T4 levels. So it will be low in overt hypothyroidism. Then there is something called as thyroid antibodies. We told that it might be autoimmune also. So anti-TPO antibody and anti-thyroglobulin antibodies, if they are present, they will confirm autoimmune thyroiditis. Most commonly we call it as Hashimoto's thyroiditis. And some other tests which we can consider in hypothyroid patients are mainly lipid profile. Often we see there will be dyslipidemia, mainly hypercholesterolemia in hypothyroidism patients. And if we get CBC, it might show normocytic normochromic anemia because of chronic illness, or there might be a picture of macrocytic anemia. This is the common investigations which we can get done in hypothyroid workup. And how to interpret the results? We know that TSH, first of all, we have to focus on T4 levels. If T4 levels are low, definitely it is hypothyroidism. Then we have to observe for TSH. If it is high, then it is compensatory because the problem is in primary gland itself. So it is primary hypothyroidism. Sometimes we told that initial stages of hypothyroidism, when there is slight reduction in T4 production or T3 production, it will go and stimulate pituitary gland. That will lead to excess TSH. That is still eligible to stimulate the gland to produce hormones. That's why we will see normal T3 or T4 levels in the early stages. This is called as subclinical hypothyroidism. Then we discussed about central hypothyroidism, in which TSH level itself is low, leading to low T3, T4. So always we have to consider these two tests. The priority is TSH, which is very helpful in differentiating primary versus secondary. We told that more than 95% of the cases are related to thyroid gland itself. So what is the problem in thyroid gland? There are some culprits which can lead to the dysfunction of thyroid gland. For example, autoimmune Hashimoto's thyroiditis, in which autoantibodies will infiltrate thyroid gland and leads to dysfunction of the gland. This is very common, especially in iodine sufficient regions. Nowadays we not often see iodine deficiency, so we can consider this as the commonest cause. Then there might be iatrogenic. For example, after radiational therapy, post radioactive iodine therapy, or thyroid surgeries, we can see the loss of thyroid gland function. Then we told iodine deficiency. We can consider it as the commonest cause, but nowadays everywhere there will be fortification of the foods with iodine. So we are seeing lesser number of iodine deficiency related thyroid dysfunctions. Then there are some drugs which can lead to hypothyroidism. Mainly we have to remember lithium, which is utilized as a mood stabilizer in psychiatric diseases, as well as amiodarone in cardiac disorders. Then sometimes there will be congenital dysgenesis of the thyroid gland, or there will be functional congenital problem, that is production of hormone will be dysfunctional, that is called as dysharmonogenesis. So these are some culprits which will lead to the gland dysfunction. When it comes to treatment, our goals should be mainly two things. One is to restore patient to euthyroid state, that is we have to normalize TSH, that is the main goal, and we have to focus on reversal of the symptoms. These are the two main things in hypothyroid treatment. So the drug of choice is levothyroxine, that is mainly T4 we will supplement with, as the gland is not able to produce sufficient hormone. Just like type 1 diabetes, where pancreas is not able to produce enough insulin, so we will supplement with insulin, right? Similarly here, thyroid gland is not able to produce thyroid hormones, so we have to supplement it. So the drug of choice is levothyroxine, and we have to remember its half-life is approximately 7 days. It is quite long. Its importance we will discuss in the upcoming slides. So often, because of this half-life, it is administered once daily. So how to give levothyroxine dosage? Standard dosage for most adults will be full replacement, that is 1.6 microgram per kg per day. So this number we have to remember. This is considered as replacement of the full dose. And in some special populations, we have to start low and we have to go very slow. In the sense, we have to begin with 12.5 to 25 microgram of supplement every day. Mainly, this will apply to any individual who is having cardiac disease or if they are elders. So we have to start with low dosages to avoid angina or arrhythmia precipitation, and it must be taken on empty stomach. This we all know. Ideally, we will advise for 30 to 60 minutes before breakfast. They can take the pill. When we see a case of hypothyroidism, so just rule out cardiac diseases, and if they are not elders, we can go ahead with the maximum dosage itself. How to follow up? We have to recheck TSH. We told that our goal is to normalize TSH and symptoms. So we have to monitor TSH every 2 monthly, we can say 6 to 8 weeks after starting, or anytime if you change the dosage, we have to tell them to follow up at 6 to 8 weeks. This is initiation. Then we know that TSH normalization is our target. So it should be typically in the range of less than 5. We can remember less than 5. So this is called as stability when we are following up the patient. Then once the dose is stabilized and the target TSH is achieved, we can check TSH annually. So this is for maintenance cases. This is how we have to follow up. In the sense, overall, we have to tell them to follow up at every 2 monthly. There is a special consideration when it comes to management of hypothyroidism in pregnancy. So what happens in pregnancy? Requirement of thyroid supplements will increase. That will increase by 30 to 50%. Average we can tell it as 40% should be there in the dosing. So what we can do for this? We have to increase the dose to 40% of current dose, or we can just simply tell them to take 9 tablets over 7 days. So generally they will be taking 1 tablet every day, right? So that will account for 7 tablets 7 days. So we have to tell them in a week on 2 days you can take 2 tablets. That will cover 40% rise in the dosages. And here one more important thing is we have to monitor every monthly in pregnancy. This is very important, especially in the first half of the pregnancy. So these are some special points related to management of hypothyroidism in pregnancy. And we have to know one complication of not treating hypothyroidism, or even if the patient is on supplements, they might face some acute stressors like infections or trauma that will lead to thyroid emergency called as myxedema coma. So what happens? Patient will present with altered mental status. Often, as the name indicates, they might be in deep coma or confusion state. Then when we check the temperature, it will be severe hypothermia. So temperature will be below normal. Then there will be hypoventilation as well as bradycardia. Overall, this hypothyroid manifestation will be very severe. All the systems will be slowed down. So that's how they will present to us. This is a condition called as myxedema coma, and it has very high mortality if we don't recognize it at right time. So what we can do? Just we have to replace the deficient thyroid hormone. In this case, the individual will not be able to take orally, as well as it is not the situation where we can give oral medication and wait. So we have to ideally give levothyroxine intravenous or through NG tube. We can give the supplements. And remember, it is very important in such situations to give adrenal support as well. So IV hydrocortisone should be given to cover any potential concurrent adrenal insufficiency. Then there is supportive care which should be followed as primary care, like for example passive warming because of hypothermia and mechanical ventilation for cardiorespiratory resuscitation. So this is one thing which we have to know. Often these will be elderly female with known hypothyroidism or underwent thyroid surgeries previously. They might present with comatose state. So that time we have to keep high suspicion of myxedema coma because it has very high mortality. Okay, these are all the basics of hypothyroidism. Then we told in the beginning that we are going to discuss some frequently asked questions or some common difficulties which we face during our clinical day-to-day practice. First of all, patient's side, they will ask, is it a lifelong condition? Answer for this is both yes as well as no. See, it is a treatable and completely reversible based on some causes. For example, if it is postpartum thyroiditis or inflammatory thyroiditis, it can be reversed. But if it is due to some other causes, for example autoimmune disorders or radiation induced or post surgical cases, it is usually a lifelong condition in other causes. So it depends on the cause of hypothyroidism. Then often patients ask for dietary advices in hypothyroidism. Here there are some foods which we can advise for better thyroid production. For example, iodine rich foods. Nowadays everywhere it is iodized salt. Also we can see iodine fortification in eggs and dairy products. So these things they have to verify and take. Then there is zinc rich supplements, especially in seeds we can tell. Then there is role of selenium, again in sunflower seeds. Often we will see this. So these things we can advise. And there is one more thing which they have to avoid or limit, that is called as cruciferous vegetables. Cruciferous vegetables like cabbage, radish, cauliflower, etc. So these they will tell impede with the actions of thyroid. That's why they have to limit or avoid these as much as possible. These general dietary advices you can give, but here the thing is diet will not reverse the condition. This just has supportive role. Main thing is supplementation or replacement of the thyroxine. Then comes some situation where individual will skip some dosage by mistake. For example, if they skip one day, what they have to do? On the same day, if they remember, they can take the tablet or take the pill whenever they remember. If it is on the same day, suppose they remember it on the next day when they are going to take their usual dosage that they have skipped the dose yesterday, then what they can do? They can take 2 pills at a time. And often we see some individuals requiring very high dosage of supplements, like more than 100 or 125 microgram of thyroxine they will be taking, levothyroxine. In such situations, ideally we have to rule out few things. For example, patient might be having pseudo malabsorption, in the sense patient is taking the medication properly, but the thing is in and around the timing of pill, they are having some food which are obstructing in the absorption of the supplement. For example, tea or coffee. So these things we have to verify. Then comes actual malabsorption. Some patients will be having malabsorption disorders. So whatever the dose they are taking might not be reaching the target. So in such situations also, they might be requiring very high dosages, or there will be some other medications which they are taking at the same time. For example, commonly on empty stomach in the morning, many of the individuals will be taking antacids, or they might be taking iron supplements, calcium supplements. So these things we have to take the history and verify when there is very high requirement of thyroid dosage. Then what about anti-TPO antibodies? When we get it done, how we have to proceed? See, it will indicate it is an autoimmune condition and it will last lifelong. Just the positivity matters, not the titer. Then what happens usually when we are starting thyroid supplements, we usually start when TSH is more than 10. We know that TSH should be below 5. So anything more than 5 is something abnormal, right? So we start supplementation when the TSH is more than 10. Or if the TSH is between 5 to 10 and there is anti-TPO antibodies positivity. So in this situation also we have to start, because this will indicate that antibodies are already there in our body. As the action of these antibodies progresses, this TSH will slowly rise. So we have to initiate the treatment at the earliest. So this is how we have to utilize the antibodies report. And remember, in pregnancy, the target TSH is less than 2.5. This also we have to remember. So anything if it is more than 2.5, consider it as hypothyroid and start the supplementation. Otherwise, if we don't start, there will be very high chances of miscarriages or abortions. This applies to pregnancy. Then there is one more doubt, why we have to get thyroid profile in fasting state only. Here the thing is, if it is a postprandial sample, food will suppress TSH levels. So when we are treating hypothyroidism patients, we are mainly worried about normalizing TSH, right? So it would have been high when we started the treatment. When they come for follow-up, and if they have food and then give the sample, it will suppress TSH and it might be falsely normalized or falsely low. This might lead to change of medications in a wrong way. That's why we have to advise them to get a fasting sample, ideally at the same time whenever they come for follow-up. And one more important thing is, they should not take the morning dosage. Morning dosage on the day of thyroid profile analysis should be withheld, and once they give the sample, they have to carry the pill along with them, then they can take it. Take it after sampling, because if they take supplement, there will be sharp spike in the levels of T4, especially free T4. This point we have to remember. So two things: one, they have to come in fasting state and they have to carry their supplement with them. Once they give blood sample, then they can take the dosage of that particular day. Then often we will not be knowing about this thing, whether to get T3 or T4, and if T3 T4, it is free T3 T4 or total T3 T4. This will be a common doubt for many students. See, here the thing is, T3 is mainly utilized for the follow-up of hyperthyroidism. That too, total T3, not free T3. As its level is very fluctuating in the body, we will not usually follow up with T3 in case of hypothyroidism. This is the first point. So for us, T4 is important along with TSH, and when it comes to free T4 or total T4, total in the sense the T4 which is freely circulating, that is active form, free plus bound form. So it will be bound to many proteins like thyroid binding globulin, TBG, and many more. So overall it will be called as total. We have to remember here that about 99% will be bound to the globulins and only 1% is freely circulating in the body, and it is the active form. This is what we have to follow ideally, which is active form. So free T4 is important for us because this binding is affected by many conditions. For example, liver diseases, or if the individual, especially females, if they are on any oral contraceptive pills. Even pregnancy will affect the globulin levels, and the individual's diet, protein levels, all of these factors will affect the bound form, leading to altered levels in total T4. That's why whenever we are following up a hypothyroid patient, always consider free T4. This is very important for us. And what about thyroid swelling? Majority of the times we will see patients will be presenting with thyroid gland enlargement. So what does that indicate? See, we know that this thyroid gland in the initial stages, when it is going into hypothyroidism, by feedback, pituitary will release lots of TSH, right? So it will come and stimulate the thyroid gland to produce thyroid hormones as much as possible, leading to enlargement of the gland. It is one way of our body to compensate for the decreased thyroid hormones. So this is one mechanism, that is, it is a compensatory thyroiditis. Or we told that in autoimmune thyroiditis there will be autoantibodies. Those will come and infiltrate the gland, leading to its enlargement. So any infiltration with autoantibodies or WBCs in some inflammatory thyroiditis, in that situation also we can see thyroid gland enlargement. So whenever we see thyroid gland swelling, do we need to worry always? Remember, we have to advise for ultrasonography only if there is hard lump, if it feels hard, or if it is lumpy feel of the enlargement, or there is asymmetrical enlargement, or if there is sudden rapid growth of the size, a rapid increase in size. Otherwise, if the individual is having any obstructive symptoms Like if the gland is enlarged so much that it is obstructing the food pipe leading to dysphagia, or it is compressing the voice producing structures leading to hoarseness of voice. So if any of these features are there, we can consider for ultrasonography and we can proceed with FNAC if indicated. But the thing is, not all thyroid swellings are need to be worried. Once we start supplementing with the levothyroxine, this overstimulation will come down and whatever compensatory enlargement is there, it will regress. This is the point. So hope you got every detail about hypothyroidism. We have discussed in depth. I hope it will be very helpful for you guys, and thank you for listening the class till the end. And I request you to comment the topic which you want me to cover in the upcoming videos so that I can prepare well and come up with the best version of the requested topic. Thank you all. See you in next video.